you very much.
Yeah. Okay, well, welcome everybody. And as Lee said earlier, I'm Martin Whittle. I'm the lay vice chair of the CCG, so I'm a lay member. We have a clinical chair, Dr. Ave Bhatia, so he's a doctor, and we have a lay vice chair, which is me, and I chair the engagement committee, which I can see there are a number of members on this session as well. This session follows what took place in June, which is really a background to what the integrated care system is going to be about and how the changes hopefully will improve things for people from April next year when the integrated care system comes into being. What we're covering in this session can be found in the link that you see in the presentation there. And I'm sure this presentation, this updated presentation, will be sent out to people because it is fractionally different from the one that went out earlier. But you can get all the detail there should that be what you want to do. There are further Derbyshire Dialogue sessions on topics related to the integrated care system taking place over the next 3 or 4 months or sooner if required. And the idea is what we're trying to do, I guess, is build a whole wodge of information for people so that they understand what we're trying to do, because it is, in a sense, a really fundamental shift. It's what the NHS and social care and others have been trying to do for donkey's years.
I'm sorry, there's a terrible echo. The echo is making it almost impossible to hear what either of you are saying. Well,
Has somebody got their sound on?
Oh, okay. Is anybody else getting an echo? Because I'm not.
No, I'm not.
I think
What sometimes happens is what I think sometimes happens, Lee, is if you've opened the session twice, and I did notice some people seem to join more than once. If you've opened the session twice, you get an echo because you're getting 2 feeds from the sound. So if you just check that you've not joined the meeting twice.
Yes, I think that is the most likely explanation for that. So if you are getting an echo, if you could just leave and see if you're already joined onto the meeting and just hop back in on the meeting link, that should sort it, because it's not something that's affecting everybody. So it must be a user specific, if that's okay. Thank you.
Okay, so yeah, we're just trying to sort of build information so that people understand it is a fundamental shift. It is something, though, that we've all been trying to do for quite a long time in terms of integrating care. But what this new guidance does, and this new system that the government are putting in place, it gives us the tools to do the job better this time. So that's the hope. We have a range of guidance that we've received over the last few months. I mean, it literally is coming in sort of daily, and then next week we'll get 4 sets coming in and things. So it is a big piece to me at the moment, really to help us develop the system, develop the architecture going forward. And again, we've given a link there where you can find the guidance if you want to look into the detail. Today, what we're going to do is try and give you a very brief summary of the guidance for implementing the working with people and communities bit of the project, and also a bit of progress on what we've done already in doing this, because we have obviously made a start at it. And then also introduce the ICS implementation guidance on partnerships with voluntary and community and social enterprise sector. So I'm doing this bit of introduction. Karen's going to do the clever stuff because she's been involved in more of the detail. So the first bit on guidance on working with people and communities. Really, it sets out the expectation that partners in the integrated care system, and I say partners in the system because it literally is that, really at early doors, it used words like there is a duty to cooperate. So no longer can bits of the system say, no, I'm an independent organisation, I'm not going to cooperate with this. It gives a duty to cooperate to everybody, all the organisations, whether they be, well, you know, an acute trust, mental health trust, the commissioning side, everybody has to cooperate to make this system work. And what it does is it sets out specifically in this area how we should listen to in a consistent manner and collectively act on the experiences and aspirations of local people. Because it's not just about saying we're going to develop these services and provide them. It's about saying, are they working for you? What's your experience of it? And can we then tweak them to make them better? That means involving people and communities in developing plans and priorities and improvement and the improvement of services, but also helping people to sustain and improve their own health and well-being. You know, it sometimes can be simple stuff. When I retired, I was overweight, and I went on one of these courses that the GP said, you know, you can go on one of these courses for people who are overweight. So I went on it, and it was really fascinating, some of the simple stuff that you just don't know. So one of the takeaways for me of that course was, if you eat the calories that you need to maintain your weight and stay the same weight, if you have one digested biscuit a day for a year, that will be another stone in weight. So it really made me think how small the variation is to putting on weight, but also how small it is to losing weight. And I've actually done nothing but lost 2.5 stone, just because I'm not eating biscuits in the office and cakes in the office and sitting. It's that small stuff. I've done nothing other than that. I've not been on a diet, lost 2.5 stone. And then of course last year, COVID hit and I got a mouth ulcer, a tooth abscess 2 days before lockdown. So I've lost another stone because I couldn't eat and couldn't get treatment for about 4 or 5 months for this abscess. That was my first 5 months of lockdown. But simple thing is, there are some things you need help with, and that's what this is also part of. This means really that we've got to involve people in developing plans and priorities, not just sort of do things to people. And we've tried to do that over the years, but I don't think we've really succeeded in doing it as well as we could. The guidance sets out 10 principles, and it is important to recognise that this is everyone's business. The idea of the integrated care system is that we help ourselves as citizens, as patients, but also everybody in the system officially, if you like, health, social care and others play their part. So what have we got to do? Well, we've got to develop a system-wide strategy for engaging people using the 10 principles that I'll come on to, and I'll whiz through the principles in a way. You'll be able to read them at your leisure, but as ever, when you get something from the centre that's designed by committee, it's often quite repetitive. But I'll go on to them in a couple of minutes. The Integrated Care Board itself, and for those of you who are on the earlier session, probably you heard a little bit about the Integrated Care Board. I won't repeat it, but they have to have a constitution. And at the moment, the statutory accountability for engagement and consultation sits with the CCG, which I'm part of. That will disappear, the CCG, at the end of March. So some organisation has to take on that statutory accountability, and that is the Integrated Care Board. So it specifically has to say how it will, you know, arrange to engage with people and communities and so on, because it has a particular statutory responsibility above and beyond what the integrated care system does and the other parts of the system do. We've got to get representation from local people and communities in the priority setting and decision-making forums across the system, including the place-based partnerships. And again, those who were on the earlier session may have learned that, in a sense, what we're trying to set up is a multi-tiered system. So you'll have the integrated care system that operates right across the whole of Derbyshire at a high level. But below that, there will be 2 places in the city and the county, and below that there will be more locality working going on, which is really where you need to start integrating a lot of the care for people at a local level. So it's about making sure that we've got engagement not just at the big high level, which is really what we've done to date, but really engaging people at the local level to say how are systems and engagement processes and services working for you in, I don't know, the Derbyshire Dales or Matlock or Bakewell or wherever. And we're also expected to gather intelligence. I touched on it before about experience and aspirations of people and how we're going to use those insights. And I think Karen's going to touch on this a bit later to inform decision making and the quality governance, because there is an element of quality of care here as well, not just what we produce. It's how good is it. So the 10 principles, as I say, they're a bit repetitive in a sense, but it is about putting the voice of local communities at the centre of the decision making at every level in the IECS. Starting engagement early when developing plans and feeding back to people and communities how that's influenced it. Again, I think that's not something we've done particularly well. It's all very well engaging people and saying, what do you think we should do with this? How do you think we should do that? But it's really good to go back to them and say, thank you for that. You said this, we did that. So I think we should do that better. And we're trying to do that as we build the architecture, if you like, going forward. Understanding the community's needs and experiences for health and healthcare, using the engagement to find out if you're having the desired effect. I remember many years ago, it's about really understanding what the community needs. I was involved in some work about drinking and young people and trying to help young people to stop drinking as much as they did, and a lot of it was about binge drinking. And most of us would say, well, what do you do then? Well, you say to the young people, well, drinking affects your liver, it can affect your mental health, it can affect your health in normal ways. You shouldn't really do it, should you? When we did a piece of work which said to young people, what is it would stop you drinking in the way that you do? It wasn't the health. They're kind of bomb-proof. They're going to get up in the morning and carry on with the day. It wasn't the health that bothered them. They said to us, one thing that would stop them drinking heavily and binge drinking is if they had a heavy session and during that session they embarrassed themselves in front of their mates. And that was kind of a revelation. You think, gosh, you sit here thinking this is what will stop people drinking, and it's way, way different from what your experience is. Next thing is building relationships with excluded groups, especially those affected by inequalities. We've got to try and reach out to lots of different groups, whether it's on an ethnic basis or just a sort of a group, an employment group. If we're going to, there's been talk over the years about mental health issues in farming communities. Well, if you're going to put on clinics for people in farming communities, don't do it on a Monday morning when half of them are at Bakewell livestock market. Maybe do something at the livestock market, but it's about being clever and intuitive about how you best engage with people. Next one's working with Health Watch, voluntary sector, community groups as key partners. We do need to do that because there's an awful lot going on at a local level. And I think that's part of the issue. I touched on it before. We've done a lot of work at the big sort of Derbyshire level over the years, or, whatever county level. I don't think we've done enough at the local level. With what the ICS gives us, working more locally, I think hopefully we'll be able to tap into that more local working with voluntary community and social enterprise groups. Next point is about really accountability. It's about providing what you do in a clear and accessible way so that you can say, this is what we're doing and what do you think about it? So that, you build that understanding and trust. I think, I have worked in the NHS for a while, and I think we have tried to do things in an open way. I don't think we always get it right, but that's part of this session. This is one of the sessions where we can say, how can we build understanding and trust better for people? Using community development approaches that empower people and communities, making local connections and social action. This is where we're getting a bit repetitive because there's lots of stuff going on in the voluntary sector where we can do things that not necessarily based on a medical model of how to help people in their lives. You can do a lot of things to help people that are not necessarily medical, which then do help their health. Again, co-production, insight and engagement is important for developing health and care services. We need to tackle the system priorities in partnership with people in the communities, and we need to learn from what works best. And part of what this is about saying, well, actually, we've done lots of engagement in the past. We can take some good things forward, but this is about a conversation with you who've been kind enough to join us to say, how can we do it better in the future and build those networks and activity in those local places in a way, in a sense, that we haven't done as well as we perhaps might have done to date. So I think that's it from me, and I'm going to hand over to Karen now. Thank you.
Okay, So I'm just going to give you a little bit of an update on the progress that I feel that we've made against those 10 principles already. And as Martin said, I think we've got lots of additional work to do. And it's probably work that we know about already, but we have made a lot of progress. So I think it's important that I spell that out to you today, and then we work together to look at how we can improve on that going forward. So this is our continuous engagement infrastructure on this slide. We've got the citizens panel, which is a group of about 1,000 people at the moment that are representative of the local population, and we email out to them and let them know about opportunities to get involved. We'll be using the citizens panel for surveys going forward, and we're in the process of migrating the citizens panel from one software to another at the moment, so it's kind of in limbo. But once it's all moved over onto the new platform, we're going to do a big recruitment campaign to increase the size of the citizens panel and increase its representativeness of the population. So that will be a kind of a really important tool for us in getting a temperature check of what people think in Derbyshire about any given topic. We've got the new online engagement platform, which Lee, who you met at the beginning of Derbyshire Dialogue, he manages that platform. It's open for any partners in the system to use, our voluntary sector, colleagues, Health Watch, the trust can use it. Anybody that basically wants to have a conversation about health or care services with the local population can use the online engagement platform. And we have a few conversations on there already, like the mental health crisis cafe work that's being done. You can go onto the online engagement platform now and have a say on that. And we are hoping to build it so that as many conversations as possible are had on the online engagement platform. So it's kind of that one-stop shop for all health and care conversations. It's got a long way to go before we get there, but that's the ambition for that platform. We've got the patient participation group network. So this is a group of PPG members who support their GP practices to improve services. We have a network for them where we keep them informed of developments within the integrated care system, and they can ask questions of people that come along to the network. And they can also suggest items for the agenda, and we try to support them in their work. So anybody who's a PPG member attached to their GP practice can join that network. And it's a really fantastic group of people. I really enjoy working with them. We've got the voluntary sector leadership programme. I think it's called now Embedding the voluntary and community sector in the ICS. I'm going to talk about that in a little bit more detail a few slides on, so I'll just leave that one for now. We've got really good connections with the BAME forum that Derbyshire County Council run, and we're currently looking at how we support that community to have a greater say in what's happening in the integrated care system. And I've also had some really good conversations recently with Derby City and the forums that they've got around the BAME community. So we're building some really good networks and relationships up to ensure that we do include those communities in our work. We've got a readers panel for anybody who wants to kind of just check out the understanding of literature that's going out to members of the public. Derbyshire Dialogue, so you're all here today, so you know about Derbyshire Dialogue. We have a Derbyshire Dialogue every month, and we have put every 3 to 4 months we've put one aside to talk about developments in the integrated care system, and we're open to ideas about what the next conversation will be. We've got this piece of work called the place involvement structures going on. It's a huge piece of work that we've been devising to make the best, I think, of all those conversations that are happening already in local communities. How do we make the best use of all those conversations? How do we create the interface between those communities and the work that's going on in the integrated care system? So we've started to set up some pilots with community groups, with the BAME community, to look at how we have those conversations, and then how we make sure that that information feeds into the work that's, say, happening in the place partnerships, but also how we support people in local communities to have agency over their own health and well-being, and what support we can put in place to make that happen. So that is a very new piece of work, but it's really critical in terms of ensuring that we're working with people around health inequalities, that we're working with people who don't normally kind of get involved in the structures like, you know, the Citizens Panel or the PPG network. It's kind of getting involved with people who already have relationships with people on the ground, and making sure that we make the most of those relationships and bring them into the integrated care system. And then we've got an initiative called the Patient and Public Partners. So this is quite new. Some of the boards within the integrated care system, like the Cancer Board, the Diabetes Board, the Cardiovascular and the Respiratory Board, are starting to recruit patient and public partners to sit on their decision-making structures, and we're recruiting people who have an interest in that work and supporting them to have a voice on those boards and work streams. So it is quite new. We've got about 15 patient and public partners already recruited, and we're going to put on a training programme in January for them, and then we hope to build on that work and get patient and public partners across the whole of the ICS governance structure. So it's quite an ambitious piece of work, but the support will be there for them. So it's not just a case of kind of having a member of public on a board and then just expecting them to be able to speak up on behalf of others. We're going to put the training in there and support to make sure that they feel confident to do that. And then we've got Health Watch, who are incredibly important within the work of the ICS. We do need to look at how we include Health Watch more in the governance structures, but we do have a really good relationship with both Health Watch Derby and Derbyshire, and we are keen to include them in our work with people and communities, and we know they're critical for that. They have got Health Watch England have produced something called Health and Care Experience Profiles, which help to understand specific at-risk groups of population. So Health Watch England have said, I've looked into things like South Asian people who have diabetes, and they look at the journey that those people have to do to navigate their way through services, and what could be put in place to make those services much more joined up and integrated. So Health Watch have got some really good methodologies that we can use in our work going forward for working with people and communities, especially those who are impacted by health inequalities. Okay, so we've got a system insight group as well, which was featured in a recent guide that the King's Fund put together as a model of good practice. So I've brought together all the patient experience and engagement leads in the system into the system insight group, and we try to work together to avoid duplicating gathering insight, and to make sure that all the insight that we have in the system is available for everyone to use when they're making decisions. So one of the things that the system insight did at the very beginning was create the insight library. So we have the insight library where people can go and they can check out what insight we already have in the system. So for example, we recently commissioned Britain Thinks to do some research into the perceptions and reality of people accessing primary care and urgent care, and the report is on the insight library. We've got reports on there from the voluntary sector. We've got reports on there from Health Watch. We've got reports on there from the patient experience team at the CCG, and we've got some really good insight coming in from Derbyshire County Council that they want to share. So it means that anybody that's making decisions about services can now go to the Insight Library first, find out what we already know, what people have already asked, the questions they've already asked, and then just look for the gaps in Insight and engage on those gaps rather than asking the same questions of the same people again and people getting consultation fatigue. And then we've got a really exciting piece of work called the integration measure that we're working with the King's Fund to put this in place, which is about making sure that we're not just gathering insight as each individual organisation. So, you know, GPs are just gathering insight about how people access GP services, and Chesterfield Royal Hospital just gathering insight about how people experience Chesterfield Royal Hospital. What we're wanting to do is start to gather insight about how people navigate their way across services and the problems that they might have. And so we're creating an integration measure with the help of the King's Fund, which will mean that we're listening as a system. So the information that GPs gather that gives insight into how people are experiencing other services within the system, we need to be gathering that all together into kind of one system-wide database and starting to understand that. We're also going to be putting some kind of questions together from a patient perspective around what good integrated care might look like. So when I talked about that place involvement work that we were doing, once we've kind of got to grips with all those conversations that are happening in local communities, we want to start to gather that information together and then look at what matters most to people and set up a set of questions that measures integration from a patient and public perspective in terms of what matters most to them. And then we want to be measuring ourselves against that perspective. So that's what the integration measure is all about. It's are we doing a good job from a patient and public perspective? So it is a really good piece of work, and it does require that we get right down into local communities and find out what matters to them. And then over the course of you know, the coming years, as we implement the integrated care system priorities, we'll be able to see if we are actually making a difference to people and how they're experiencing integrated care. And then co-production, which is something that I've always wanted to embed into the integrated care system, is now written into the guidance, the ICS guidance. So this is very much about involving people right from the beginning, which people I think struggle with because they feel that they shouldn't go out and talk to people until they know what they want to talk about. But sometimes it's good to just get people involved in those initial conversations. You know, what is it that we actually need to be looking at changing in the first place? And so we're going to be trying to embed co-production within the integrated care system, within all the transformation programs that are taking place. And we're looking at how we do that and how what tools we need to put together to make sure that that can happen. And we're setting up a task group to look at that and to look at the good practice that already happens within the system, because we know that there is some good co-production already taking place. So that's, you know, if anybody's interested in getting involved in that task group, then they just need to get in touch with me because I'm heading that up at the moment. Just some other developments that I wanted to mention as well. We've got a suite of ICS explainer guides that inform people about the vision and plans and progress of the integrated care system, and they're available on that link. There's lots more to follow. They're just kind of the beginning, really. So as different parts of the integrated care system start to develop more fully, we'll be putting together guides that explain those different aspects. So, for example, partner collaborations is one of the provider collaborations is one of the terms that we bandy about in the integrated care system, but it's really difficult to understand what that means. So there'll be an ICS explainer guide on those provider collaborations at some point, giving you more detail. There'll be a ICS explainer guide around place partnerships, giving you more detail. And if anybody has any suggestions as to what they would like to see in an ICS explainer, then you've only got to ask and we'll look at putting that together. We do already have a transparent decision-making process with Joined Up Care Derbyshire meetings being held in public, and we do publish the minutes and give regular updates on progress. We have a vision for a public partnership committee. I'm just going to bring in Martin Whittle again here to just say a few words about this. Is that okay, Martin?
Yes, of course, sure. And in doing so, I'll try and weave in a couple of points that a couple of people have made, Patricia and Peter made, about the governors of trusts and how they could be involved or are involved. So at the moment, we have an engagement committee, and there are members here who are on that. So the Jocelyn Street and Steve Bramley, I can see they're on the call. They're members of the engagement committee. What the engagement committee tries to do, and it was set up this way, is to almost hold a mirror up to the CCG and say, when you're making changes in services, we're going to look at those changes and check that you're doing it, you're engaging in a way that's in line with good practice. Because the CCG has to assure itself, as its board has to assure itself that it's doing things properly when it makes changes to services. And so what the engagement committee does is it looks at what happens when there's a service change and says, that went well, this is good, could you try to do something different? Unfortunately, since I've been involved as chair in the last couple of years, we've not had a lot of engagement because of COVID. We've been in survival mode, so there hasn't been a lot of service change. So the engagement committee hasn't done what its really core function is, hardly at all. But that's what it's there to do, to help make the CCG make the right decisions and do things properly with good practice. On that committee, we have public governors from each of the NHS organisations, and we also have Health Watch, and we also have people like Steve and Jocelyn, who are what you might just term members of the public as opposed to governors. So we do use them currently in the governance structure in terms of scrutinising how we're doing things and suggesting how we could do things better. So we would hope to be able to do something similar. What we're moving towards, and the CCG will disappear, so I will disappear metaphorically, or the role, my role will disappear, but I'm helping to try and set up the future, and it's purely a working title at the moment, a public partnership committee, because we're trying to make it, I suppose, sound like what we want it to do in the future. And that committee will probably have to do something in terms of that governance, because the Integrated Care Board will still have that statutory responsibility like the CCG does. So the Public Partnership Committee will probably have to do that role that it currently does in terms of helping the CCG to keep safe in terms of best practice and doing the right things. But we also want to see if the Public Partnership Committee, if it indeed is called that, can do something different in terms of, actually coordinating, helping develop some of the ideas for engagement, rather than just this more core governance role that it does. And that's work in progress at the moment. We've just started the conversations about that. We're going to have a conversation with the engagement committee about it. And when we come up with some ideas, they will go forward to the people who will be the ICS in the future. All I can do as the engagement committee chair is make some recommendations and put forward ideas. It'll be for others who are involved in the future to make the decision about how it happens. But there will be some form of committee which tries to bring together all this work and present it to the, if you like, the Integrated Care Board and the Integrated Care Partnership Board to say, this is how you're doing in terms of engagement. It's good here, it's not so good there, and it may have a wider role. So that's where we've got to at the moment, work in progress, but definitely something that we want to take the good from what we're doing now and make it better in the future. And answering Peter and Patricia's questions or points, yes, governors are involved, and my hope is they would be involved in the future, because you look at all the governors across the system, we've got a huge pool of people that we can access in terms of engagement, people who are interested in healthcare in the particular sectors that we work in. But it's wider than that, of course. It's about how can we work across local government, working across social care, because we are trying to integrate things. It's not just about the health system now.
Thanks, Martin. So I just connected to that really is that we have developed an engagement model, which is kind of like a flow chart of all the different processes that really every transformation program should go through. So for example, they need to be checking out what insights are already available. We need to be doing pre-engagement with patients and members of the public in order to look at what the impact might be of any transformation, and to look at the criteria that we need to judge any potential solutions or options on. We need to be doing options appraisal, development and appraisal, and making sure that patients and members of the public are included in that process. And then, and this is all before we get to that kind of public consultation phase at the end, if it's a significant development or change to services. So we've got an engagement model that takes all decision makers through each of those processes, and I'm more than happy to share that with people if you want to have a look at it. It's still in draft because we're also writing a governance guide that sits behind that engagement model to give people who are making decisions more detail about all the different aspects of different stages of the model and what they need to do in order to make sure that they are including the voices of patient service users, communities and staff at an early stage, and ensuring that they are influencing those transformation plans. So like I say, I'm more than happy to share that, but I wanted you to know that it's also been integrated into something called Joined Up Care Derbyshire Improvement, which is being led by Maria Riley. And I thought this might be something that you might want more information on at a future Derbyshire Dialogue. But basically what they're doing is putting together a digital project management office, which means that all transformation programs in the system will have to be inputted into this digital PMO, and they'll have to go through a series of kind of prompts and gateways within this system that will mean that they are putting robust governance processes in place. And part of that will be that the engagement model, all the different stages of the engagement model will be in that digital PMO, so they won't be able to kind of get to another stage in that process until they've done that relevant and robust involvement of patients and members of the public. So I think it's quite an important thing for you to know about that. And also it means that the engagement team will be able to go into that system, look at all the transformation programs that are taking place, and we can assure ourselves that there's been appropriate patient and public involvement from an early stage in those programs. So it's a way of us controlling as well, that of us controlling that process. So I am hoping that we'll be able to get Maria Riley to a future Derbyshire Dialogue to give you a bit of an overview of Joined Up Improvement Derbyshire, and that system should be in place by the end of December. And then also I just wanted to just very quickly introduce you to the ICS implementation guidance on partnerships with the voluntary community and social enterprise sector. And the reason for that is obviously that the voluntary sector is huge. There's over 5,000 organisations in Derbyshire alone, so that's not including the city, and 10,000 full-time equivalent staff. And it's critical for facilitating access to communities and articulating their need. And so it's a really key strategic partner within the integrated care system. And by April 2022, the Integrated Care Board is expected to have a formal agreement with engaging and embedding the VCSE sector in system level governance and decision making arrangements. And what they're hoping is that's going to be through a VCSE alliance, which will reflect the diversity of the sector and be their voice. So if any of you in the audience are from the voluntary and community sector, then Wyn Garnett is the programme lead who's kind of progressing that agenda, and there's a whole kind of checklist within that implementation guidance that he's working to. It has a steering group and a kind of a sounding board group that he uses to support him in that work, and he's always happy to hear from other voluntary sector providers that want to inform the way that that might look, and hopefully that's all going to be in place by April 2022. But the reason I'm kind of bringing it up is because obviously, as well as a key strategic partner to the integrated care system, the voluntary sector is also a key route into local communities. And so, you know, we really do need to kind of strengthen the work that we do with all manner of VCSE sector organisations. We're already trying to do that as part of the place partnerships involvement work, particularly with the BAME community. But we're also looking at it in terms of how we collect together the insight that that sector has and feed that into the patient and public insight library. So we're doing lots of work with the voluntary sector is what I'm trying to say. And so if you're interested in hearing more about that, we can also make that a future session of the Derbyshire Dialogue. So I'm going to take my presentation down now and open it up to questions.
Okay, fantastic. Thank you very much. And thank you, Martin and Karen, because you have covered a few of the questions that as they've come in through the chat. So I'm just looking through now, and we've got quite a few kind of political ones as such around kind of where's the money for this coming from the integrated care system. And I don't know if that's something that we could kind of answer for. There's just been a few comments about, you know, how is this actually going to happen, because of that link in with some of the comments about perhaps poor service delivery of late. So is that any one that could be picked up on? I know it's tough when it becomes mired in politics as well, because we're somewhat bound by the guidance that comes out as it comes out.
Are they comments specifically around the voluntary sector, or just generally how we're going to deliver on the integrated care guidance around people and communities?
They're more general, but I suppose linked into the fact that, well, we've seen, you know, many changes over the years that have supposedly been introduced. What makes it different with the ICS coming into play, and how is that going to work?
Yeah, so if it's about funding for the whole of the integrated care system, I don't think that's actually something I can specifically answer. If it's about funding for the work with people and communities, then I can say that there has been a commitment made to, so for example, with the place partnerships involvement structure, where I said we were going to look at what conversations were being had in local communities and create those interfaces to make sure that their voice was being heard in the integrated care system. There's been a commitment from the place partnership subcommittee to making sure that the funding is there to make that possible. And I think that there is a huge commitment to making sure that people and communities do have a voice in the integrated care system. And I think that that will be funded appropriately. In terms of the voluntary and community sector, then I think that's something that could be picked up if we do a conversation around the implementation guidance for the VCSE, around that embedding the voluntary and community sector in the integrated care system. So we could pick those questions up in that conversation, because I know that that is, you know, that is a key question. And I suppose what, you know, we rely more and more on the voluntary sector, and we've seen how quickly and flexibly they can kind of rise to a challenge during the pandemic. And so that question is coming up more and more, and I think that we could have that conversation during that. In terms of the financing of the integrated care system itself, Martin, I don't know if you, as you sit on the board, if you've got any comments to make about that.
Yeah, I mean, there is sort of politics in this, isn't there, about how much money the NHS gets and so on, and that's kind of for another day, I think, because we can't sort that today. You know, we get allocations from the government, and that's kind of set centrally. But I think once the money gets to Derbyshire, I mean, currently what we've got is the CCG is the commissioner, which crudely put, buys the healthcare on behalf of the population from the providers, and you have a contract in that, and it's kind of always been felt to be a bit clunky, and it becomes a bit of a, you know, it can get into a bit of a pitched battle of, we need more to do this, well, we've only got this amount of money, so you kind of get nowhere. The idea of the integrated care system is you kind of do away with that and that conflict, if you like, and say to providers, well, look, we'll all work together, we'll discuss what the priorities are, and then we'll make allocations accordingly. Now, that's a really difficult thing to achieve, but I made the point earlier about this duty to cooperate that's in the law, which says that you can't just sort of say, oh, I don't agree with this, I'm walking away. You're in the system. So there is, you know, there are going to be things that all the partners in the integrated care system are going to have to do it at a county-wide level, because that's, you know, services sometimes are at that level. Sometimes they're pan-county, you know, specialist services and so on. But what we will have the facility to do now, which we haven't had before, is at place level give allocations to places for them to set more local priorities, and even below that. And that's where I think the gains will be made, because working in localities, working more locally, you'll be able to understand the priorities, integrate services. The idea is that it will become more efficient, which will hopefully then free up a bit more money to do more with it. So kind of that's the theory. It's got to happen in practice, and it'll take an awful lot of goodwill and partnership working to make it happen. But the idea is more local money will be decided at a local level, and therefore hopefully you'll be able to do more local work with local community systems, voluntary sector, community groups and so forth. That's kind of my take on it.
Thank you very much. And then just looking through some of the other comments, and I'm mindful to try and keep it, especially given we've got 8 minutes left, to the theme of this session, though there's plenty of good points that we'll pick up and get back to individually. About the care and about the role of volunteers within the integrated care system. So we talk about needing to include the voluntary sector and the organisations themselves, and that will, you know, give roots to making it much more inclusive and embedding that into the structure. And thank you for any comments about the work we've done on kind of putting the infrastructure down and architecture to try and enable that in a better way than has been done in the past. But about specifically, there was a question about the role of volunteers within themselves within the integrated care system. There's been a few comments on volunteers, and is there an expectancy that there'll be plenty of roles for volunteers to play within that?
I think the role of volunteers still very firmly sits within the voluntary and community sector. And they will still, I think, so Kerry Fletcher is the system lead for volunteering within the integrated care system. And I think that might be something that we could bring up as part of the conversation about the VCSE implementation guidance, maybe at the next Derbyshire Dialogue, because there is kind of a lot of work going on around volunteering and how we maybe create kind of a volunteer passport that makes it easier for people to kind of volunteer across different agencies, and easier to kind of mobilize volunteers, for example, you know, like with the pandemic, if we need to do that. In terms of actual involvement of people in communities in the engagement side of things, in terms of, you know, service changes, we do look for volunteers to sit on boards, for example, to be the voice of patients and members of the public. But those roles are kind of only in development at the moment. And, you know, at the side of the voluntary sector and their volunteering programme would be very kind of small and insignificant at the side of that. So I think that's something that we probably need to pick up in that future conversation.
Okay, brilliant. Thank you very much. Now, I'm going to, and it's always a tricky one, this, because we've got the 5 minutes left notification I've just seen, and I'm going to go to some hands now that we've got up. So thank you for being nice and patient there. Just going to come to them in order. I've got Leslie showing up as first on my screen. Leslie, do you want to come in?
Hi, Leslie.
Hi, thanks very much for both the presentations, and congratulations for trying to be so ambitious and start at the top and work down. I think that's really refreshing to see and hear. I'm looking forward to being able to contribute and to be part of a lot of your activities. I'm just wondering how I will be able to go out and show the public the organisation of what has been set up, where they would go to find out about these certain groups, how they might be able to connect with them, and what the relationship is between them. Do we have a diagram that sort of pulls it together, or gives me something simple? Because actually at the moment I am a bit overwhelmed.
Yes, I do appreciate that, Leslie.
You and me both, Leslie.
So it's kind of it's one of those things that we've just, you know, and I've noticed Jenny's comment in the comment box as well about, you know, is this just the usual suspects? And, you know, I think that's what we've been trying not to do, is to just make it the usual suspects. We've been trying to put together a layered approach so that people can get involved, you know, online, they can get involved through their local community groups, they can get involved through their PPGs, they can get involved through Derbyshire, you know, all the different ways that people like to get involved. And so we've been concentrating so hard on trying to get all those different methods up and running that, like you say, I think now we need to concentrate on how we make people aware of all those different methods that there are, and ensure that we also gather all that insight together so that it is informing the work of the integrated care system. And that is, and I think, you know that, Leslie, and I know I've spoken to you about this in terms of GLOSSIP and making sure that it's part of that place involvement work that we're doing. I think that's what that work will do. It will help us to have those conversations with people on the ground and learn how we need to kind of get those messages across and how we can support people in the best possible way to know what's happening in the integrated care system. So I do see a lot of that happening as part of that work, and I'm looking forward to working with you on that in GLOSSIP.
And can I just add, I think, Leslie, thank you for the question. I think it's really important, because sometimes, you know, yes, there are wiring diagrams that we've got now, but I think that they are, again, our kind of work in progress for the internal system to try and work out what we've got to do. But I do think we need to, over the next sort of 6 months, when the ICS formally comes into being, to have a suite of things that are user friendly to everybody, and I think that will come. So, you know, we're just doing the work now. So I noticed Steve says, what earlier session? I think he's referring to my question when I said we'd had an earlier session at the engagement committee a couple of months ago. We said we were going to have a session with a few people to just sort of bring together the guidance, bring together the structure of the ICS as it's currently understood, and then we're going to take it back to the engagement committee for a conversation. So they've got some context within which to have the conversation.
I'm just thinking
and then
there are
once we've done all that, I think, you know, we'll then be able to say, this is what it looks like for people to go out and use.
Yeah, certainly aware that we've got, and I'm sure everybody else has got groups where you could road test some of these things and you get really good feedback as to how much sense it might make to the average person on the street.
Yeah. And of course, whatever we do isn't fixed. We can change it. We can adapt it. Lee, I don't know about other people, but I'm happy to stay for a few minutes longer to take some questions in if we can. I don't know if we can.
Okay, fantastic. If that's and I appreciate some people will have to drop off the call now, so thank you very much. If we keep it running for another 5 minutes or so, then if that's okay, and we'll try and get through a few more questions. I'm gonna stick with the hands.
Sorry, I'm gonna have to leave at 12 o'clock if that's okay.
Yeah, that's absolutely fine. Thank you very much for coming, Michelle. I appreciate it. It was very last minute. Thank you.
Thank you,
okay.
Michelle.
All right. Thank you. Bye bye.
Okay. So yeah, just for the purposes of getting through while Martin's happy to answer some questions, and Karen's sticking with us. So I'm sticking with the hands, sorry. So I'm going to come to Valerie. Valerie Broom.
Hi, Valerie.
Thank you. Hi, can you see and hear me?
I can hear you.
Yeah, you should be able to see me as well.
I can see you, Valerie.
Okay, thank you. Thank you. Yeah, on this topic of the volunteers, and as Karen knows, I am somebody who, I'm retired, I'm 71 years of age. I do a lot of engagement stuff. I'm happy to go to committees and stuff, but I think we're a dwindling population, and I am concerned that this setup is going to rely so much on the voluntary sector and volunteers, and that it could collapse under the weight of its own structures. And I mean, I'm all for engagement. I think engagement will improve things. However, I did say earlier, don't let's forget that NHS is already doing a good job. There are issues which you're going to tell me are political about funding and understaffing. And I just wonder how much engagement is going to be able to affect some of the fundamental issues that underlie the health service we get. And you know, I hope that us volunteers and voluntary sector aren't just going to be used to cover up some of the underlying problems that the NHS has. Thank you.
I don't know if Martin, you want to come in on that, or do you want me to?
Well, I would only say I hope we don't, and I do think this is, you know, I as the chair of the engagement committee, I do sit on the Joined Up Care board, and all the conversations I hear are about people wanting to do things differently now. So I don't think it's going to be sort of, you know, let's just dob it all into the voluntary sector and let them sort of deal with it. I genuinely think there is a view that we don't use the voluntary sector in the way that we could and should, and that we could do it differently and better. And I don't think there's any sentiment that if we do it differently, we'll just be giving it to them without funding and so on. You know, all I can say is what I'm hearing as a lay member sitting on that board, I'm hearing all the right noises. I appreciate that isn't action. It means nothing until it is action. But I do think people are setting out in the right direction to get it right, if that helps.
Can I just
even a little bit?
To say that, you know, I've just seen, well, I knew about this anyway over the last month, but the Mental Health, Learning Disability and Autism Board, which is part of the integrated care system, I've just put together an open statement for the voluntary sector, and they're sending that out to everybody that they know of in the sector, spelling out all the different initiatives that they have within their portfolio of work within that board, and asking for expressions of interest from the voluntary sector to deliver that work, because they know that a lot of the important and key work around mental health, working with people with learning disabilities and autism sits within the voluntary sector, and that work will be fully funded and fully recognised within the work of the integrated care system in that board. So I think that does kind of represent what Martin is saying, is that they are looking for new ways of working with the voluntary sector, recognising the contribution that the excellent contribution that they make, and recognising them as a key provider of services within the integrated care system, and funding them appropriately to do that.
Okay, brilliant. Thank you very much. I've got a hand up from Peter.
I think there's Richard Smith trying to as well. He's putting his hand up physically.
Right. Okay. Sorry, I'll bring you in, Richard. Apologies. I can't see everyone on my screen, so I'm a little bit, yeah.
Okay. So my question is about the non-criminal roles of the police. I'm a neighbourhood watch person, and we get alerts to ask us to look for people who have not returned home. They're not criminals, they haven't broken the law, they simply haven't returned home. And it's alleged that most of them are sleeping in Markeaton Park, which is on the edge of where I live. None of the emergency services, the police, fire or ambulance, appear in the structure, although they all have a social role. The police definitely don't go around looking for criminals all day long. The ambulance service most definitely doesn't take people to hospital all the time. The firemen spend as much time talking to people about their problems relating to incidents, explosions, accidents in cars, and I didn't see them in this wondrous jigsaw of organisations. And I would also make the point that Health Watch is one of the only bodies that actually is created by law, if I remember my PPI days.
Yeah.
Yeah.
Shall I start, Karen? Because there's a really interesting slide, and linking it back to Leslie's point. There's a really interesting slide that's being used at the moment to try and develop the way we're working and the way of being for the future. And what it says is people's health outcomes. If you look at people's health outcomes as 100%, only 20% of it is actually determined by the services the health service delivers. The other 80% is, have they got work? Have they got an income? Have they got good housing? Do they live in damp conditions? All the stuff that you're talking about, Richard. So yes, we're starting out from the viewpoint that there's an 80% of stuff that happens that really affects more than the health service in terms of people's health. And the ambulance service is on the Joined Up Care Derbyshire board. There are conversations with the police, with all those other services. So I think you'll find it is happening. And as we develop the way of being for April, some of those things will become more evident, because we are trying to say, let's not just look at the 20% that we can deal with directly in terms of delivering healthcare. It's the 80% that the health service can't directly affect. That's really what we've got to go at. And actually, yep, the reason I linked it to Leslie, that might be a useful slide that gets put out there for people to understand just the issues that we're trying to deal with, because it'd be helpful for the public to understand it's not just the health service that deals with people's health, if that helps.
Yep, go along with that.
Yeah, and I think on that kind of social role point, the wider determinants, as Martin's referring to then, and yourself, Richard, are kind of strongly being considered, and there's lots of work going on linking in with what are being called anchor institutions, such as, you know, key institutions within Derbyshire that have a social role to play, such as Rolls-Royce, Derby County Football Club. All of those have, you know, a big kind of impact within the community. So the police, the fire service, and everyone, they are being involved in this, and as part of that 80% that Martin refers to, which is really kind of one of the underlying premises of an integrated care system, not just looking at the health bit.
Yeah, and we heard we had a session with the Joined Up Care Board last week, and it's something like 84, those anchor institutions, just those few employ 84,000 people directly. So if you imagine each of those 84,000 people has a family, very quickly you're covering a large part of Derbyshire when you're starting to do things. So.
Okay, brilliant. Now, I appreciate there's going to be lots of questions in the chat, but we can get back to those. So I'm just going to take one last one now from Peter, because I have to leave myself. Peter, do you want to come in?
Yeah, thanks, Lee. Good morning, everybody. I just firstly like to say what a fantastic session this has been. There's been some brilliant information, which was certainly news to me. So it's really helped me tremendously. I think the Public Partnership Committee formation is going to be a fantastic idea. And the co-production approach that Karen raised as well, again, is absolutely brilliant. So if it's okay, I'll drop you emails to both of you on those two particular points offline. My main question is to you, Lee. There's been some great discussions in the chat. Is it possible to actually circulate the discussions that are in the chat in addition to the video?
Yes, I can do. What I think I will have to do, just in terms of GDPR and data protection, I'll have to take the names off them. Because but I can circulate the comments. I can download the chat box and circulate the comments, but I'll have to take the names out, unfortunately.
Okay, brilliant. Thank you.
All right.
It did somewhat make me regret using my weight loss as an example. There was a slightly disputatious conversation about fast food outlets, but I was trying to make it real for people. Yeah,
no, brilliant. Well, thank you very much, everybody. I appreciate there's more comments in the chat box and stuff, and we'll do our best to get back to those. We'll circulate the things that we've said we'll circulate, such as the engagement model, the recording of the session, and some other bits that I've made notes of. So I'm going to draw this meeting to a close. Thank you very much, everybody, for coming. We have got another Derbyshire Dialogue session set up. Is it Quality Conversations, the next one, Karen? But the invite and information hasn't gone out for that yet, so everyone on the list will get the invite for the next one, along with the meeting recording and whatnot for this. So thank you very much, especially to Martin as well, and Karen for presenting, and we'll see you all soon.
Thank you.
Bye.
Bye.
Thank you. Bye.
Many thanks. Bye.